When you have coronary artery disease, one or more of the blood vessels that supply your heart with oxygen and nutrients has become narrowed or blocked. Left untreated, coronary artery disease can cause you to feel pressure, tightness, or pain in your chest, arm, neck, or jaw. Over time, coronary artery disease may cause a heart attack or sudden death. While there are other procedures to help treat this heart problem, your doctor thinks angioplasty and stenting may work for you. Understanding angioplasty and stenting. Angioplasty widens the channel where blood flows inside an artery. During angioplasty, a tiny balloon is used to push plaque against the coronary artery walls. Stenting uses a small wire mesh tube to help improve blood flow to the heart. A stent is placed permanently in a coronary artery to hold it open and help keep the affected section of artery from becoming narrow or blocked again. Some stents slowly release medication within the narrowed part of the artery. These are called drug-eluting stents. The medication keeps scar tissue from forming around and in the stent, helping to prevent this blockage from forming again. How the heart works. To understand angioplasty and stenting, it helps to know more about how the heart works. The heart is a muscle that pumps blood to all parts of the body. Like other muscles, the heart needs a steady supply of blood in order to work right. Blood carries oxygen to the heart and the rest of the body through blood vessels called arteries. The coronary arteries wrap around the surface of the heart and supply the heart muscle with the oxygen-rich blood it needs. The left anterior descending artery supplies blood to the front and left side of the heart. The circumflex artery supplies blood to the back and left side of the heart. The right coronary artery supplies blood to the right side and bottom of the heart. A healthy coronary artery has no blockages. It has smooth, flexible walls that can accommodate changes in blood flow. When a coronary artery becomes damaged, a fatty material called plaque builds up within the artery wall. This is the beginning of coronary artery disease. As plaque increases, the channel where blood flows inside the artery begins to narrow. Over time, it can become so narrow that the artery can no longer respond to any increased demand for blood, such as when you're climbing a flight of stairs or are under emotional stress. Once the artery becomes too narrow, you're likely to feel pressure, tightness, or pain in your chest, arm, jaw, or back. This is a warning sign that you are at risk of a heart attack. After plaque builds up, it can rupture, narrowing the artery even more. The rupture may cause a blood clot to form, blocking the artery. With either event, blood flow below the blockage is reduced or cut off completely. This can result in a heart attack. During a heart attack, some of the heart muscle below the blockage doesn't receive enough oxygen. That part of the muscle dies and the damage cannot be reversed. Though many people survive heart attacks, a heart attack can be deadly. Before your procedure. Your doctor will talk with you about how cardiac catheterization can help diagnose a heart problem and, in some cases, be used to treat heart disease. Both angioplasty and stenting can help improve blood flow to the heart, but they are not a cure for coronary artery disease. Understanding the risks and knowing what to expect during and after treatment will help you feel more relaxed and confident. A catheter is a long, thin, flexible tube that is inserted into your body through a small needle puncture in your groin. Sometimes a puncture is made in the arm or wrist instead. The area will be numbed before the puncture is made. From the puncture site, the catheter is carefully advanced through the arteries into the heart. Video monitors allow your doctor to watch the catheter as it moves through your body. This process takes only seconds, and it causes no pain. Once the catheter has reached the affected coronary artery, X-ray contrast dye is injected through the catheter. This dye allows your doctor to see the artery on the video monitor. By looking at the picture of the artery, your doctor knows where the artery is blocked and how large the blockage is. This information helps your doctor decide if angioplasty will work. It also shows your doctor where to put a stent. Next, a guide wire is sent through the catheter and maneuvered through the blockage. This wire helps to position the balloon-tipped catheters used during angioplasty and stenting. In some cases, before a stent is placed, the path through the blockage is widened to increase blood flow and ease placement of the stent. This process, called angioplasty, uses a balloon catheter that inflates to open the channel. You may feel chest discomfort or your usual symptoms during angioplasty. Tell your doctor if you do. After the angioplasty, a stent may be inserted into the coronary artery on another balloon-tipped catheter. Once positioned through the blockage, the balloon catheter is inflated. This causes the stent to expand and compresses the plaque against the artery wall. More than one balloon catheter may be used to fully open the stent. In some cases, a blockage may require more than one stent. Once the stent is fully expanded, the catheters and guide wire are removed. The stent remains in your artery permanently, holding the vessel open and improving blood flow to your heart. If a drug-eluting stent is used, medication will slowly be released from the stent. This helps keep the artery from narrowing in this area again.
Watch some video. What an interesting way the world has become flat now, that a Gujarati doctor living in North Carolina interacting with a North Indian physician living in Long Island and an Indian physician now in India, in Baroda, and we all trying to share and help South Indian community, Telugu community, with all the know-how that we have developed over the last 30 years. I think each one of us have been practicing for about 30 years cardiology and in each of the area. And so you have a really talented team in that sense. I can't tell myself about much, but I know Dr. Chauhan is extraordinarily good and I will trust my life with him. And same way, Dr. Gupta, I know last few years and I have seen his talent. So let's move forward. When we talk about heart disease and you saw the video, the so-called cardiovascular, cardio means heart and vascular means blood vessels. So is this heart problem only one that you just now saw the video or we will be talking about, or is this multiple? So it is very interesting to know that heart disease, it's like when the house collapses, house can collapse because of multiple reasons. There could be a fire, there could be flooding, there could be a bulldozer coming in and so on and so forth. So there is a variety of things that can afflict the heart. And some of them are totally benign, of no consequence at all in your life, but it really scares us a lot. While others, which may not cause you much symptoms, but you drop dead, as somebody just now mentioned. So this is an interesting spectrum, and that is what the task of a cardiologist is, to see if someone comes with some symptoms, is there a problem or not? While symptoms may bother a lot to the patient, to the physician, it is not necessarily the symptoms, but what are the chances that the person would suffer a life-threatening problem in the near future or at the end of the life or by the time the life moves forward. So that is the interesting part. And some of the minor things that we have seen, or a variety of things that we have seen in heart disease, ranges from just palpitation or abnormal cardiogram to dizziness, to a heart murmur, high blood pressure, inflammation of the heart, to the weakness of the heart muscle, aneurysm or dilatation, blood clot in the lungs, people born with the defects of the heart. So people born with the defects could have a problem at 6 months of age or right at the birth. We might find a problem and it may need to be fixed up. So a variety of spectrum is there. And the same way, the cardiac arrest that was mentioned just now, even though 80–90% of them are because of a cholesterol related blockage in the heart tube, there is certainly a group of people who die suddenly. The so-called sudden death or so-called cardiac arrest may not have anything to do with the heart. The person died because there was a bleeding in the brain. The person died because of a stomach tube being ruptured and blown apart. So there are reasons for sudden death other than a blockage in the heart tube also. So it's worth keeping in mind. But since this is the most common and does affect our Asian community rather more, that's a reason for this discussion. Today's topic we are limiting to the so-called CAD or coronary artery disease. heart catheterization, stent, balloon. Our primary aim is not to discuss more advanced things, but to discuss basics of this to understand what heart disease is, how and why we are prone to it, how to pick up early, and how to prevent it. So this is our primary emphasis for today's talk. A very nice view of the heart. And keep in mind that the heart, when we talk about, we are talking about physical heart. When we say somebody's heart is crying, that has nothing to do with this heart, even though you may feel palpitation. So this is the physical heart which sits in the chest. It's the size of your fist. And it pumps out the blood in these red tubes that takes blood to the arms, to the brain, and to the legs. And it receives the blood back from all these organs through these veins, which are blue colored. And it itself gives blood to the heart muscles themselves. Need a good amount of blood that comes from these tiny tubes, which are visible here, called coronary arteries. These are coronary means heart tubes, basically. So these are the heart tubes which are normally wide open, and they get a cholesterol buildup from inside. The blockage narrows the tube, and ultimately complete blockage causes damage of a part of the heart. That is what we call a heart attack. So heart attack is as simple as a plugging of our water pipes in the home. It grows slowly and ultimately clogs up that the water cannot flow. Nothing more to it on a day-to-day basis. And when the balloon stent is done, I showed the video earlier, but basically if there is a blockage, we put a tiny wire with a balloon on that. Balloon is inflated, and a stent, which is a steel mesh or a not necessarily steel, but a artificial material, which sort of gets embedded in the wall, opens up the tube, and the tube becomes wide open. And the way now it is being done, almost 90% will stay open over 10-20 years without much problem. So it's a very effective treatment, is available when needed. Not everybody needs it, but when needed, oh my goodness, this could be life-saving, no question about it. So let me invite some of our speakers here. Arunji is here with me. And Dr. Gupta, we all know heart disease happens, but why as a human am I prone to heart disease? If you can enlarge on that, why do we even develop it? What are the mechanisms?
So it's very interesting. You laid out a very nice basic information about heart disease to everyone, but why does this happen? So everyone, think about your own families. If your father had heart disease, or your uncle had heart disease, your grandfather had heart disease, perhaps it's genetically mediated, and you're born with it. You're born with some abnormal genes that cause lipid abnormalities. Lipid abnormalities, for example, you should have looked at your lab work. Look at your triglycerides. Are your triglycerides elevated? Look at your HDL. Is your HDL low? Look at your LDL, the bad cholesterol. Is the bad cholesterol elevated? That actually puts a risk factor for a particular person. Now, obviously, a person who is 10 years old or 15 or 20 years old may not get heart disease. And on the other end of the spectrum, a 60-year-old, 70-year-old, 80-year-old is expected to have heart disease, because that's how aging manifests in us. But there's a large segment of population between 30 and say 55. Let's call them an intermediate group. Why should these people be at risk? So again, think about yourselves. Is there a smoking history? Is that a factor? Yes. So people who smoke, they tend to get heart disease. Do we eat the wrong foods? What are the wrong foods? Do we eat fried foods? Do we eat high carbohydrate foods? Should that be a risk factor? Look at the difference between Caucasians and South Asians. South Asians, us, we tend to have smaller coronary arteries as opposed to Caucasians. We tend to do more urbanization. There's a segment of population that has moved towards becoming rich. We eat rich food. We are using cars. We are not exercising. And that has tended to increase the risk of heart disease. And these are all our lifestyle changes and our choices.
You would, Arunji, you would say that basically either there is a combination of inherited factors like genetics and then the lifestyle. These two combined probably to result in a propensity to blockages. Aging is obviously a third factor, but these two are basically there even for the aging to play a role. And then are there an additional environmental factor? So this slide summarizes well what you mentioned. And the subsequent one, and I was surprised to know that 50% of mummies had plaques also. So even millennia ago, this disease did exist. And frankly, one of the reasons we are living longer, in addition to controlling the infection, is the controlling or preventing the cardiovascular problems there. And why Indians are at a higher risk? Let me invite Dr. Chauhan. You might need to unmute, Virendra. About what is your feeling about heart disease in Indians? If you can tell us in a nutshell and highlight on this, slide that.
I agree with Dr. Gupta ji said. But when we say the factors we predispose to heart disease, we call them cardiac or coronary risk factors. Amongst them are the diabetes, hypertension, lifestyle, genetic factors. But one of the important risk factors being Indian, means Indians in India as well as Indians abroad, they have 3 times more risk of heart disease compared to Caucasians and Southeast Asian or Chinese people. So being Indian, unfortunately, is itself a risk factor, which is because of, again, combination of genetic predisposition and faulty lifestyle. Our diet is though vegetarian, it is considered as a contaminated vegetarian diet, and that increases the risk of heart disease quite significantly. Amongst Indians, Punjabis, Gujaratis, and Keralians have probably higher incidence of heart disease compared to rest other states. So among South Indians, I think if you're Keralians, your chance of getting heart disease is a little higher compared to rest other states. So that is what we considered. And on an average, about 15 lakhs people die because of heart disease each year in India. So the coronary artery disease burden in India is quite high. So India has suddenly, from famine-like situation, has gone to affluenza. So we were already predisposed to genetic factors for the heart disease. And suddenly our lifestyle has changed a lot. So we get heart disease 10 years earlier. We get more diffuse triple vessel disease. Our vessels are smaller. So to treat the Indian patient with angioplasty and surgery is more difficult compared to the Caucasian patient. So that is what we have seen in our practice. Of course, we don't get Caucasian patients. We get in India only Indian patients.
Virendra,
but I see them getting 10 years earlier.
Virendra, let me give you a worldwide view, since our audience is all over the world, that in the world population, if I have to put it from my understanding, the people from Pakistan, Bangladesh are probably at the highest incidence of heart disease or prevalence of heart disease in the population. Indians are probably second. In South Indians from Kerala and that side is even more compared to some of the other communities. Caucasians are lesser. Africans probably the third. Africans and Mexicans, if I have to put it. And the Chinese and Orientals have the least heart disease incidence or prevalence. So this is how roughly it goes. I may be slightly off in the comparing between Caucasians and Africans, but the Chinese and Orientals have the least. Unfortunately, when the Japanese or Chinese people come to United States, their risk becomes more, and partly contributed by not only the lifestyle, but also the stresses and the change in their overall milieu. So they do have an increased risk once they come up here. So there is some change in the situation. So these 2 slides summarize well what Chauhanji is saying, where the incidence of heart disease from 2000 to 2015, a significant rise in number of heart disease patients in India, and the burden, especially at a younger age, 30s, 40s, not 30s, but 40s and 50s, but all of us have seen heart disease, even in 20s. One of my youngest patients was 22, but I'm sure Dr. Chauhan in India would have seen similar situation. The high case fatality ratio and other things are relevant too. So, and interestingly, there has been significant increase in incidence of heart disease in India from 1970 to 2013, and now this is 2022. So as he rightly said, the prevalence is rising partly because of the affluence, lifestyle changes, and so on and so forth. So while in United States, because of the aggressiveness of and the availability of the resources and mass understanding of targeting cholesterol at a lower level, educating the people what we are doing now, all this has resulted in plateauing and actually decrease in the deaths in thousands from the heart attack from say 1900 to 2008. So the sharp rise that was there in between has reduced significantly. So that is interesting observation there. Let me invite, now in general, when we say heart disease, we know normally, as somebody mentioned at the beginning, that a person died suddenly, there was no warning. But is it really a sudden disease? Does it happen overnight? A normal heart tube, which is wide open, start developing a cholesterol buildup, and it gradually increases and blocks up at one day. That transition is at least several months to several years of timing. Usually plaque buildup is over years, not over days. So you had it is like a fruit ripens on the tree, but falls suddenly. So when that sudden event happens, that is a terminal event, usually when the plaque ruptures and the tube fills up. That is how the people come to us. So we see many people with blockages in all the tubes that they never knew. And one day we did a catheterization and picked up there are multiple blockages, requires bypass surgery, balloon stent, but the disease was developing over months and years. And that is where we, or the current medical evaluation comes in picture, which our Indians lack in a big way, where a targeted attention to preventing heart disease is not undertaken. There is no surprise in the heart disease by and large in the current era. I cannot believe that there could a heart attack happen which was not detectable few years, often 5 to 10 years before the event happened. Yes, exceptions do exist, but by and large, in 80–90% of the people, you'll be able to take an early warning that there was a problem. So let me invite, that's what I mentioned just now, that what are the initial symptoms? Arunji, if you can give a small suggestion to the people, what are the initial and subsequent symptoms?
So as the slide depicts, sometimes the presentation is just basically a massive heart attack or death, which is in almost 50% of the population. But generally, people will have symptoms with some chest pain, chest tightness. They're walking and they feel during exertion, they feel some heaviness. They feel like something is blocking their wind in the chest. But majority of the episodes are really silent. Any kind of symptoms in a woman that may be different than what I've just mentioned should be taken not lightly. For example, pain going into the arm, pain going into the neck, a jaw pain or shoulder pain, or pain in the abdomen, in the upper abdomen, could be some of these symptoms. But most of the times, some of these are associated with some nausea, sweating, and they all need to be looked at. And unfortunately, as it's been mentioned already, sometimes the first presentation is sudden death, which is unfortunately a terminal event, but it could have been looked at 5–10 years before in order to prevent this. And some of those are as we mentioned, risk factors. Again, look at yourselves, ourselves. We should all think about this. If we have family history, if our abdomen is somewhat bigger, measure your abdominal girth. Take a look at this.
I have put Arunji this way divided in our slides, as our people can see. There are unchangeable risk factors, and then if you can enlarge on what you are enlarging on are the changeable. Go ahead on those, please.
Yeah. So look at the slide now. As it says, changeable or modifiable risk factors. Control your blood pressure, control your cholesterol. If you have high blood pressure, high cholesterol, as far as the obesity is concerned, as I was mentioning, it's simple, very simple. Check your abdominal girth. For women, if you are above 80 centimeters, that's too much. For men, above 90 centimeters is too much in the Asian population. Check for diabetes. And there's a term called prediabetes. For prediabetes, change your physical activity, go exercise, stop smoking, modify your alcohol intake. And if we go to so that's
interesting, isn't it? So, I mean, we are trying to put in a nutshell, but let me get back to the symptoms wise. We need to understand the heart disease comes to us as a physician in two separate ways. One are the people who have a long term over the last few weeks or months or sometimes even years, when they walk, somehow they are limited. If they're just out of wind or they have a discomfort in the chest, it's usually not pain. Heart pain is not pain, even though it is used as a pain. People come with a just feeling of uncomfortable feeling in the chest that even they cannot verbalize that what it is, but they feel something in the chest on exertion and stopping with the stop at rest. This is the classic. The discomfort occurs to many, and often it is because of acid reflux, because of other reasons. But when something is related to exertion, you climb 2 staircases, you walk half a mile, something which you used to do 6 months ago, and now you feel something limits you. If it limits you in the chest, it is because of blockage in the heart tubes. If it limits you in the leg, it is usually because of blockage in the leg tubes, which is a counterpart of what happens in the heart. When there are blockage in the leg tubes, we call it claudication, but basically the calf muscle tightens up and limits your activity. So something that limits your exertion is called exertional angina, or and indicates that a blockage is developing in the heart tubes. However, when the blockage transits to a complete blockage, then suddenly your symptoms change, that you feel a more pressure, tightness, heaviness, which does not go away, which remains there, and often accompanied by either nausea or sweats. These are the clue to me if somebody sweats during the bad chest discomfort. Now, the bad chest discomfort in heart attack does not have to be bad. There are many people where the discomfort is relatively moderate. They had it a few weeks ago, a few months ago. It again happens, but this time he breaks out in sweats. He's nauseous. He becomes cold and clammy. These are the indications to us that heart attack is developing. I don't want to send that patient to home if he had a chest discomfort 30 minutes ago or 2 hours ago and was accompanied by cold sweats. I would rather admit him in the hospital because he's developing heart attack. So a good clue. Go ahead, Arunji.
Yeah, there's a misconception. A lot of people sometimes will get heartburn, and almost almost 1/3 of the population sometimes thinks that heartburn is just GI related. But be careful, if you have risk factors, that could be the presentation of heart disease. Keep that in the back of the mind.
Right. There are atypical symptoms, and atypical symptoms are worthwhile addressing, where heartburn is one, shortness of breath alone is second, feeling of sudden dizziness that you went, or just losing strength for 20-30 minutes, you don't know what happened there, is another one. Fainting spell rarely can be a primarily presenting feature too of a heart condition. So people could have, while classic symptoms in 80% or so would be discomfort in the chest with pressure, tightness, heaviness, we do a different varieties or different types. Or sometimes patient comes with a persistent vomiting and we don't know the reason. Patient had a discomfort in the chest, but either patient ignored or we ignored. So a variety of ways people come to us, but primarily it is a pressure, tightness, heaviness in the chest, which is a good clue. This one is worth understanding, the risk of heart disease versus development of a heart attack. What are the, I mean, many people have a mild diabetes, smoking, or cholesterol. One of the factors, VCC, if you can highlight this relevance of this slide, what makes it, how do we know the chances, what are the chances of a person developing a heart attack over the next 10 years?
See, more the risk factor, more the chances. That is very nicely, clearly written, of which diabetes is one of the strongest risk factor. And second is family history. If your father, mother, or first relatives, they have a heart attack at 40, 50 years of age, your chance of getting heart attack at the same age increases. Now, if you are on the top of that tobacco chewer or smoker, it may invite heart disease maybe a decade earlier. In Indian people, India is considered diabetic capital, and that's why probably risk of coronary disease increased significantly. But sometimes there are patients who do not have any known risk factor and still they get heart attack. And unfortunately, we see even 30, 40 years young people without any known risk factor. So maybe there are some risk factors that we are not knowing at this particular moment. But in general, smoking, diabetes, hypertension, cholesterol, tobacco abuse, stressful life, lack of activity, these are the factors. This can increase chance of heart attack, and more the factor earlier it comes. This is the reason why we get heart disease in Indian 1 decade earlier compared to Westerners, in diabetic 1 decade earlier compared to non-diabetic risk factors. So that is I would consider. And one point I would like to add is the cholesterol deposition starts as early as 7 years of age. So you have to start healthy life not after the heart attack, but as early as younger age or teenagers. Once you're teenagers, you must follow the healthy lifestyle rules. So that is very important, because there are risk factors which are not changeable. And if you are too late, means to get a heart attack and then start acting is like taking action when the patient has delivery. You have to take action much earlier if you want to prevent and delay the heart disease. And if you can probably control the risk factor, you can increase your lifespan by 10 to 15 years. That is what I'd like to add.
So in a heart disease risk in medical way, we see it is what are the chance of someone, an individual at age 50, what are the chance in next 10 years he is going to have a heart condition. And a heart condition means either angina, heart attack, sudden death, balloon stent, or bypass surgery. These are called cardiovascular. You can add a stroke to that also, because that's also a component of cardiovascular. So if your next 10-year chance of heart attack or heart problem is 20%, it's considered high, because 1 in 5 out of such individual would have a problem over next 10 years, while 1 or 2% is considered low. So keep in mind that even if you have a no risk factors, once you are 50, especially in the Asian Indian population, you probably have a couple of percentage risk to begin with. So as he rightly said, there are risk factors which are still not well known. Every decade we come out with something new that now we came to know that this is a more important, or it is as important. So while we are covering or we are learning a lot of territory about heart disease, I wouldn't say we know everything, but we know sizable things. One risk factors like high blood pressure or cholesterol or smoking, your 10-year risk is between 5 to 8%. 3 risk factors, when you are multiple together, 10 to 15%. If you already have a blockage anywhere in the body, either in the heart or in the brain or the leg, your 10-year risk is 15 to 20%. So highest risk category people are worth knowing. A person already has a blockage, obviously is a high risk over next 10 years. Diabetes with family history of early heart disease. If you have a cholesterol buildup anywhere in the body, it indicates that your propensity has already started, especially if this is in the 40s, 50s, and 60s. Frankly, I have seen patients as young as 40, 50-year-old, 60-year-old male or female, where they did a dental x-ray or a CAT scan of the teeth. In dental x-ray picked up that the cholesterol deposition was noted as a plaque on the brain tube in the carotid artery. That is a warning to me. A 50-year-old woman especially, or even man, having a cholesterol buildup in the brain tube is a big indicator to me that this person's next 10-year risk is not 2-3%, its risk is more than that. So cholesterol buildup anyway, and nowadays there are excellent means available, so easy to pick up this cholesterol buildup. And I think in the whole today's presentation, if you can take home even this message, that you have a choice to pick up cholesterol buildup in the tubes anywhere in the body by very simple non-invasive test, I think you have done service to yourself. A less recognized risk factor is a kidney problem. So if you have a kidney weakness, even a mild weakness in the kidney, like that your creatinine is slightly high, you are in an early stage of kidney dysfunction, then your chances of heart attack becomes more. The more the risk factors, more the problem. Obviously, that is there. Diabetes has been highlighted a lot. Let me invite Arunji to comment on diabetes, because since that is a primary problem for Indians in general, how would you put together, does diabetes means you are doomed, or are there ways to help them?
So again, diabetes is based upon a study about 13, 14 years ago, was classified as a heart disease equivalent. Means anybody who has diabetes, as Dr. Parikh mentioned, the 10-year risk of heart disease in this person is the highest. That's how these diabetics are classified. And there's 3 types of diabetes. Type 1 is where someone at a young age gets diabetes and they don't have insulin, which is worse. In these people, the risk starts much earlier. The second type is type 2, which happens in adults, where due to either lack of activity, physical activity, or gaining weight or obesity, where their BMI, what is body mass index, which everyone can go and calculate their own body mass index and look at it. For Caucasians, it should be less than 25. but for Asians, South Asians, and us, it should be less than 23. And that is called type 2 diabetes. It's due to having insulin, but not being able to utilize it. And here also, it increases the same risk as like type 1. Again, it'll start earlier compared to people who don't have diabetes. Then if you add other risk factors, high blood pressure, high cholesterol, and as Dr. Parikh mentioned, if you have evidence of plaque, even on a simple chest X-ray, if your aorta shows a little bit of calcium plaque, that is considered a significant factor.
So, I mean, I think this slide would summarize well major problem, that there is no single risk factor, so no single solution, and necessarily we have to attack each of these factors there. You know, where you were mentioning about the metabolic syndrome, we have a very nice slide. This is less understood problem, what is metabolic syndrome. But before you develop frank diabetes, and some people may not develop diabetes necessarily, but you will see this in many of your friends where they have a little big belly, they have a borderline sugar, borderline high blood pressure, a little low HDL in 30s and 40s, normally 50 plus, and little high triglyceride like 200 to 50. And the cholesterol is, and this is peculiar in Indians, Arunji, isn't it? Correct me if I'm wrong, that cholesterol is often 180, 200. It's not very really high. And the bad cholesterol LDL is hardly 110, 120. And they think that that is fine. This is not bad at all. This is average. But when the other factors are there, big belly is there, when the early sugar problem is started, blood pressure is elevated, then they need to be careful that they are heading towards further problem. So one of the more advanced cholesterol tests that has helped here, and some people may consider it, there is something called LDL particle number. There is a international company which is located actually in Raleigh, North Carolina, and creates a more advanced cholesterol test called NMR lipoprofile. That gives you a little more insight into bad cholesterol, which is LDL, and can highlight, is there a problem or not? So in some people, I do it usually once in a lifetime. You don't need it often, but somebody could have a cholesterol of 120 or LDL, bad cholesterol of 120, but the particle numbers, which should be ideally below 1,000, is almost 2,000. So then you realize that the person's risk. So there are so many ancillary ways available to know the risk factors for the heart disease that it is possible to find out what's going on. Dr. Gupta, you could continue. Probably this is a very interesting slide. You may be able to highlight better how to pick up the people early for early and aggressive intervention. The group, couple of hundred people that we have here, what would you tell them? What is the take-home message in this slide, that what can they do today if they are, say, 30, 40, 50 years of age?
So this is a nice segue to, again, look at ourselves, look at our family, look at the family history. Again, if somebody's young, 20 years old, they probably just need to have their lipids checked. Somebody who's older, they are at very high risk. But people in the middle, so let's start at the age of 35 to 45. Start looking at, as we mentioned, look at your BMI, body mass index. Look at your abdominal girth. Look at your lipids. Look at your blood sugar. A1C is the culmination of 90 days of blood sugar control in your blood. Look at that number. Kidney disease, we mentioned, creatinine. We mentioned the LDL particle size. If LDL, LDL basically, to understand, there's two kinds. There are multiple kinds, but for this discussion, there's the large, fluffy LDL. So think of it, it floats in the blood, goes away, but small, dense LDL will fall and get stuck to the blood vessel. So the NMR profile that we mentioned, at least once have it checked to see if you have the small, dense LDL or the fluffy ones. So those people are at risk who have small, dense, and the high numbers. Lp(a) is kind of experimental and difficult, but it can be measured. The Indian population, the South Asian population, has a little higher number of Lp(a). Along with this goes ApoB and ApoA1. These are lipoproteins for people who are interested in the advanced thing. They're welcome to talk to me later on. But these are measurable, and these do define a higher risk for people. There have been studies done where they've looked at the plaque in the leg, and a simple bedside test can be done called ankle brachial index, where they check the pressure in the arm, pressure in the leg, and the numbers can tell us if the circulation is being impaired. Look at the carotid artery. Carotid artery is the artery that goes in the neck. If there is plaque there, higher chance that there's plaque in the heart. Vice versa is also true. Coronary artery calcium score has been well studied. Those people who have coronary artery calcium score of 0, the risk of heart attack, future heart attack, is very low. The cutoff is 400. Above 400, the overall mortality, especially mortality from heart disease, is much higher. If you do the coronary calcium score in serial every 7 years, 5 years, 7 years, and if it keeps going higher and higher, your risk is higher. It should be done, especially in our patient population, again, not in a 20-year-old, but say a 45-year-old, 50-year-old who does not have heart disease, has risk factors that we've all mentioned. Look at the risk factors, go get a coronary calcium score. Insurance doesn't cover it, but it only costs $100. We all blow $100 for a dinner. It's worthwhile spending $100 and getting a coronary calcium score, and look at the number, what number you have. If you have a high number, you have risk factors, you have a chance to have identified the coronary, that your risk is high for a coronary event, and take action, early action. You can perhaps save somebody's life and sudden death, as we've mentioned, from coronary artery disease in the future.
Let me explain, since you brought it out, what calcium score is. This is the CAT scan of the chest, where you see in the middle the heart, and these are the tubes, coronary arteries, which in a normal CAT scan, these are seen as a similar density as the surrounding heart. So this is one artery, the second artery is somewhere here. So these arteries normally are visible just as like a normal heart is visible. But suppose if these arteries have a cholesterol buildup, cholesterol itself is not seen by the X-ray. But this cholesterol invites a small amount of calcium to get deposited there, just as in a home, our water pipes get hardened by the soap, and that deposits as a stone and it makes it sort of junky inside. Same way that calcium, which is an innocent byproduct, it's nothing, calcium doesn't do any harm, but it's like a degenerative changes. If that happens in those tubes, then that CAT scan would pick up calcium buildup in the heart tubes, and the radiologist measure them, given a point to each of the point on that, each of the pixel is given a point, and they add up that, and the machine tells us, is the calcium score 0, 50, 200, 500, 1000, or 5000. So the whole spectrum from 0 to 5, one of my patient highest was 6000, but my calcium score last year at 63 years of age was 0, and so also at 47 when I did first time. So this calcium score being 0 suggests that the heart tube hardening has not progressed in any significant way. Keep in mind that the beginning of the hardening, just the cholesterol plaque is not visible by calcium score. So if your calcium score is 0, you should not be in a lull. If you have a diabetes, if you have a family history, if you have a smoking, I would rather be careful, even if calcium score is 0. But still we know that despite the risk factors, he has overall done well. Suppose the calcium score is 200 or 500, then we know the hardening has started in a significant way. Age-adjusted normograms are available for all population. What is an expected or average? There's no calcium score is never expected. Presence of calcium is an abnormality, but we commonly see a 70-year-old, say, Caucasian male coming to me, has an average score of, say, 20 or 50. Does it mean his heart disease risk is not there? No, heart disease risk is still there, but it is not unusually high compared to an average 70-year-old person. So the calcium score is seen with respect to your age. Females calcify later and less than males. So with your sex, your background, like African Americans have a different proportion of, a slightly different proportion of calcium score than Indians, than Americans. So your racial background. So there are normograms available. But as a physician, we grossly see that a 50-year-old male with a calcium score of 100 is very abnormal, while an 80-year-old male with a calcium score of 100, I'm not as much torn by that calcium score compared to a 50-year-old male. Obviously, the implication of a coronary event at 50-year-old are very different than 80 or 85, though both could suffer a heart attack. So I wouldn't misunderstand the implication, but the problems is the 50-year-old male with a calcium score of 100 has a lot more attention needed because he's prone to premature heart disease. So that is the recent availability of a very simple X-ray of the heart. There is no injection involved. There is no dye involved. There is no side effects other than a small cost and a radiation. There does is a radiation, so it should not be done indiscriminately. And the person who is interpreting it needs to understand how to interpret it. Otherwise, you see a small calcium and you will start scratching your head and go into depression. It doesn't make a sense to me. Be with a cardiologist who can guide you whether this is reasonable, this is unexpected, and so on and so forth. Person who already has a blockage in the heart tube or a leg tube, they don't need this by and large. I still occasionally do it, those who have a leg tube blockage, to see if they have a heart tube. So it is very peculiar that you could have a 90% blockage in the leg tube and heart tube may be nice and clean. So unfortunately, it is not that this disease happens everywhere in the same proportion. It can be much more at one location than the other. So sometimes you can use it, but once hardening is there at one place, I know the person is at a higher risk of hardening there. In general, the calcium score scale is, if it is 0, that means there is no calcium and the risk is quite low. Score less than 100 means a mild risk, moderate risk, and a severe risk above 400. But again, I had a patient with a 5,000 score, and when I did an extensive workup, the blockages were not bad at all. And a lady who had a 250 calcium score, the blockages were so bad that they needed a bypass surgery. So it is not a one-to-one relation. We need to understand these are statistical figures. An individual person, you may need to look at symptoms and stress test findings to guide them further. What next? Now the million-dollar question is, what can we do? Virendra, if you are there, if you would like to highlight on these factors, would be helpful.
Yeah. See, basically, prevention is better than cure. So as far as coronary disease is concerned, even if we see some patient die suddenly, the history of coronary disease, a buildup of cholesterol takes few decades. So enough chance for preventive actions. And even if after you get the disease, you have to continue that healthy lifestyle. First and most important is obviously diet. And majority Indian people, they are always concerned about the diet. So I would advise that healthy Indian diet should include non-fried food. Avoid fatty diet as much as possible. If you're non-vegetarian, fish and chickens are allowed, but red meat, completely no. It should not be fried. We should, you can use 1 or 2 teaspoons of ghee, but should not be used as a frying material. If you use oil, you should probably try to avoid deep frying as much as possible. I think in South India, very much fond of dosa. Dosas are probably more dangerous compared to idli because you have to fry it. So that is most important thing. Second thing is exercise. No other medicine can prevent heart disease as effective as exercise. So in Gujarati, we call it 40 pachi 40 nahi to 40 nahi. That means if you do not walk after age of 40 years, your chance of getting heart disease increases. In fact, walking is the most effective, cheapest, and easily available means to prevent or delay the heart disease. So I would advise everyone, don't be potato couch, start walking. Whenever you have time, there is no need to walk necessarily in the morning hours or 6 kilometers at a stretch. Even if you get small time period in between, short recess, short period, probably start walking. Anything you can do on walking, you prefer walking compared to using vehicles. That is most important. Smoking is 100% no. Alcohol in moderation is allowed. In India, more than smoking is probably tobacco abuse. And I've seen that even in America, Indians have managed to get the tobacco. So tobacco, you have to completely avoid. It's zero. There is no tobacco allowed at all as far as heart disease is concerned. If you are a heart patient or if you have multiple risk factors, you must use medications as per the suggested by your physician or doctor. Like aspirin is one of the most effective medicine to delay the heart disease, though the role of aspirin in female is not as proved as it is in male. If you have diabetes or hypertension, these two are partially modifiable risk factors. So if you keep diabetes and heart disease under control, you can delay the heart disease. Now remember 2 important points about both this disease. Diabetes and blood pressure both are silent killers. Majority people feel that, oh, I will no idea whether my blood pressure is high or low. But to be very frank, both the diseases are more often silent disease. So you must get them regularly checked. and you must take the medicines completely, even if you feel totally healthy and you feel no symptoms at all. Because as we previously mentioned, many totally asymptomatic people can die suddenly because of heart disease. So you have to keep blood pressure and diabetes very well controlled with diet, exercise, as well as adequate medication. That is important. Once you get major disease, like if you get a heart attack at that time, no yoga, no pranayam, nothing works. You have to immediately go to the hospital with angioplasty capability and get artery open as soon as possible, because that is the only area where angioplasty saves the life completely. While if you are already heart disease and you have symptoms which are not controlled with medication, you have to undergo ultimately angiography. And depending upon the type of blocks, if it is 1 block or 2 blocks, we can do angioplasty. If there are multiple blocks, if you're diabetic, if the blocks are in left main vessels, there are certain criteria, then we may have to consider even bypass surgery. So angioplasty in time, in emergency especially, and surgery in a preventive fashion can definitely give you extra 10 to 15 years of life. So that is very much advisable, because the one slide contains so many, I didn't go into much detail, but if even for diet, we can give 1 hour lecture on what should be the type of diet, as for example. So Dr. Pankaj Parikh will show the other slides on Mediterranean diet.
Yeah, Virendra, hold on a second.
Yeah,
So since there are several different risk factors, the strategy to address is also in a multi-pronged fashion, right?
yes,
So
yes.
diet is only one component. Some people highlight diet too. I just now was talking in the morning, one of my family member, he had a bypass. Actually, Virendra did a heart stent and then bypass, or cath and bypass. And he told me he has stopped all the salt. And I told him he will become lose 20 pounds of weight and lose the fun of life if he stops all salt. So diet has to be depending upon what kind of heart problem you have it. That's how I would put it. Excesses, I'm going to come in the next few slides, should be avoided. So diet is one component of the whole management, and so also exercise, so also smoking, so also medications. I would not underestimate the relevance of medication as and when needed. Either doing too much medication is stupid, and either not doing the medication when needed would also be wrong. So both ways there is a problem. Same way blood pressure, diabetes control, and same applies to stent and bypass surgery. Often a misconception goes that doctors are doing too many stents and too many bypasses and vice versa. But listen, by and large in the contemporary era, even in US and I know in Vadodara what happens, that people are very careful and selective in doing what we need to do. So when needed, these are extraordinarily helpful means there. Does it mean it cures everything? Not necessarily. But they are helpful means to tide over the crisis and move forward. And the same thing applies to the new heart and transplant also. Since all have a questions of diet, let me come on this diet situation where Mediterranean diet is well known. But to me, it is very simple. Moderation in the diet is the key, if you ask me. And moderation means you eat what your body needs, not just because ton is available or it is just so yummy. So simply put, eat less out means more homemade stuff in the restaurant. It is hard to accept and expect. Forget about hygiene. I'm talking about heart healthy, diabetes healthy food, because they are full of not only junky fat, but full of white carbs, and just the portions are so much. Eat natural and less processed food. And the simplest example I give to the patients is a hummus is worse than the chickpeas. So you're much better off in a sprouted beans and the whole grain, whole wheat, rather than maida, rather than a white carbs, which is full in the majority of the Indian diet. So if these two are kept in mind, a lot of ills of the diet would be put aside. I would personally think eat less out, eat more natural and more processed food. Plant-based foods are always worthwhile. So having a sizable portion of fruits and vegetables, whole grains, legumes, and nuts. I think if you keep this in mind, I think rest of the things will fall in place. Replacing solid fats with liquid fats. Oils, not necessarily olive oils, but oils in general are better than solid fats. Ghee, I would put an exception. And frankly, many Indians have sometimes a habit that all oils are bad, and I wouldn't put that way. Oils have a role, or fat does have a role in the diet because it cuts down the amount of white carbs. It allows more satiety. So properly and judiciously used, they are reasonable. Rather than deep frying, if you can air fry, if you can saute the foods, it's much better off. Body has been created with a lot of leniency. God allows us a lot of ability to enjoy the food, but if the enjoyment of the food becomes a primary, aim or a misguided aim, then you have a problem there. Limiting about the meat, there is often a question whether meat eatings are worse than the other way, or vegetarian. I tell you, the vegetarians have as much heart disease as the meat eating population. So that is a wrong conception that the meat is necessarily bad. Properly used and understood, even the meat has no problem in that sense. So limiting the meat in a certain portions would be worthwhile. Again, your dietitian and physician could guide you further. Fish and poultry has some role. And a wine, we often get a question who love drinking that wine is good or bad, and I don't recommend necessarily for that purpose. But I've seen that somehow those who drink a light amount of the wine not necessarily have an increased risk. There is some suggestion they may have even decreased risk, but I wouldn't recommend for that purpose alone. It has its plus minuses, but I tried to put in a nutshell what that means. Let me move to the next slide. The more important thing is to avoid too much of the white carbs. And this is worthwhile understanding what is glycemic index and glucose load. People can email me later on or just Google it. You will be able to find this, what it means. Too much of fried foods, too much of the saturated and trans fats. Trans fats is dalda. Saturated fats are in majority of the cookies and cakes and yummy stuffs and all our Indian sweets. They are full of both this. All the frozen Indian foods that are there in the shelves are full of trans fats and saturated fat. The fat there is from a much worse kind of oil. I missed the name in my mind, but those frozen foods in Indian stores, they need to be revamped. I would probably avoid them as far as possible. Obviously, I don't have to tell much about this food. I mean, it is very self-explanatory. And another one, I mean, these portions are just huge there for all that it matters. But a far better way of eating would be to have a good portion of such sprouted beans, chickpeas, etc., with fresh fruits, and would make it a big difference. But keep in mind that I can't bank on diet alone to cure or prevent heart disease. Very, very important thing to keep in mind, that on an average, diet does lower cholesterol, but it is only by 10 to 15%. What is needed in a person who already has a propensity for heart disease is to lower the cholesterol by 50%. And even a very small dose of cholesterol medication called statins do it very well. Now, taking statin alone and not following diet would also not be reasonable. Having reasonable diet and then when needed using cholesterol medication, I think it's very relevant. Many people either take the cholesterol medication half-hearted, or they take it and stop it and wait till the heart attack comes back and then start taking it. That will not be good. Taking cholesterol medication is not going to make you feel better because they are not designed for that purpose. They are not going to make you walk longer. They are designed that over next 10 years, your chance of heart attack becomes about 30 or 40% less. So if you have a 15% chance of heart attack, and if you take a cholesterol medication, your chance of heart attack becomes about 8 to 10%. The best of the cholesterol medication, that is where we reach. It doesn't make everything normal, but it does reduce it because there are additional factors like smoking, like diet, like exercises, and many unknown factors too. Who knows it? Everything about the heart. But this is kind of where we stand. So when needed, cholesterol medication are very helpful. Occasionally muscle aches and pains, rarely decrease memory, two important side effects, but both are manageable if you are in a touch with a physician who can guide you. Muscle aches and pains usually go away if vitamin D is replaced or if statin type is changed. So there are ways to work around that. The deciding factor whether to use cholesterol medication or not is not the cholesterol level alone, but overall risk factors. If you already have a cholesterol buildup, then I don't need to look at cholesterol level to use cholesterol medication. You will need a medication. I need the level only to know how aggressive to become, whether you need one or two medications. So keep in mind that the underlying heart disease would decide whether you need a medication or not. And that is why those calcium score or ultrasound scanning of the carotid artery at an appropriate age comes really handy, whether to decide which way to go when in doubt. So presence and extent of risk factors and presence of plaque buildup would decide whether to use cholesterol medication or not. I think the exercises and lifestyle we have spoken enough. I will move forward with this. Most of the slides, they are very nice. I discuss about the cholesterol medication. Aspirin role, a lot of people have a question whether to use it or not. It was being recommended for everybody above 45, 50 years of age in the past, till we realized that aspirin taken lifelong does have a risk of bleeding in the stomach. People do bleed, and sometimes sizable, even a one baby aspirin a day. So the suggestion there is that if you have a high risk factors, especially if you have a plaque buildup in the heart tube or the brain tube, then you use aspirin, otherwise you avoid. So aspirin use has been somewhat curtailed. I frankly, being 64, I'm still not taking it. My calcium score was 0 and my other risk factors are low. So you could customize, and people have come to understand. Also, if you have a tendency to bleed in the stomach, like if you have an ulcer in the stomach, if you are taking painkiller medications like ibuprofen, etc., which normally can irritate the stomach, if you're drinking too much alcohol, if you bled anytime in the past, all these are warning signs that you're likely to bleed in the stomach, then aspirin is no good. I must mention about this medication beta blockers, which are extremely helpful if you already had a heart event already. They are worthwhile. And so also blood pressure and diabetes medications. A lot of people ask about alternative to statins. I wouldn't go at the moment. Diet is certainly the key, but statins have an extremely useful role. Let me invite Arunji to, or we see either way. I think in India, CPR is not being practiced as much, but let me tell Dr. Gupta to comment on CPR training, which I think Indians lack in a big way. We just want to turn eyes away from that. There is nobody is going to have a collapse in our family or friends. Till I tell you that we had a meeting in the temple, and one of the gentlemen sitting on the dais collapsed, and my physician friend, Dr. Kumar, ended up doing CPR on him in the temple without any resources there. Luckily, physician was there. Person didn't make up, unfortunately, but CPR training is worthwhile understanding. Arunji, if you can give a few moments of this on this. CPR training has its own role. Most important thing is to be familiar with this, with the basic management of it, to stay calm at that time. And that is what it helps. If you had a training once, you know what to anticipate, what to do at that time, whom to call for it. And the initiating CPR is not as difficult as it may look like. Yes, doing it for 10 minutes is demanding, but hopefully by the time, at least in US, you will get somebody available there very quickly. So that is worthwhile keeping in mind. VC, let me ask you, how does that play a role? Are we doing it more often in educating the people in India at the moment for CPR?
Unfortunately, in India, lay people are not actually trained what is CPR. CPR is a cardiopulmonary resuscitation. So whenever anyone gets suddenly collapsed and the circulation stop, we have to immediately start circulation by external massage of the chest, about 100 beats per minute. And there's special ways, but all medical and paramedical staff, they know it very well. We have 108 ambulance services all over the India. So the moment anyone is collapsed, they we call the ambulance. These people know how to do CPR, but many times it will be too late in the traffic congestion, other things. So I know that in Seattle and certain cities of America, every child also knows how to do CPR. So I have heard that if you are dropped dead on the road in Seattle, at least one person will come and jump and start CPR. So ideally, it should be all over the world, all over everywhere, because of course, even if you do excellent CPR out of hospital, CPR saves only 10% people, but even 10% saving seems a big way. And as Pankaj, you know, the new CPR does not include mouth-to-mouth breathing, which is what people are little scared of. But as far as operation is concerned, it is easy, it is doable. Only thing to make patient lie on the flat surface. Don't get panicky. Don't start to make patients sit, because that will reduce cerebral circulation. Many people, they try to get up the patient and try to help him walk and take somewhere else. Let the patient lying down wherever he is. Stay calm. Immediately call for help and start CPR on one other hand. And that is what would work the best probably. So
I mean, again,
we may not be able to.
We may not be able
to. It's a golden hour that actually majority heart people, they die because of ventricular fibrillation. And if you give one thumb and one CPR, probably you can save some of the life. So CPR is actually golden hour.
Virendra, hold on. See, we may not be able to go in the details of the CPR, but I would suggest it is not as complicated as it looks like. Even I think Ramji was going to put a link here that on YouTube you can just being aware how to handle an acute situation in the most basic way is also a good starting point. Sometimes you may be near a available defibrillator machine, which is so easy to use. You put 2 pads and give a shock, and I tell you, people will come back alive within seconds. So CPR and the defibrillator use sometimes is very easy to start with, but most of the people would get uptight seeing that somebody is collapsing. They would lose the nerves. They would not be able to handle it. So the idea is to be familiar that yes, you can do something at that time rather than do nothing. I think that is the most important person. Your comfort level would decide, your calmness would decide whether you are able to help the person you want to help. But if you are shouting and if you get bugs of what to do, you will not be able to do it. So I would seriously suggest to take a basic life support care, how to put the person on the side, whom to call, and how to handle for a few minutes to keep the person going. And if you have by chance, if there is a defibrillator machine available, how to use it and when to use it. So I think those take-home messages can be helpful. Let me see the interventions we have discussed. I don't think we would have a time to go into that. Let me put a take-home message at the end that we all need to know our enemy, educate ourselves and the family, be proactive, reach a qualified physician. It's important, and I've seen time and again, and I know some of my family members are general physicians. There are extraordinary general physicians, but since the heart disease is the most common problem and an average Indian would face in their lifetime, it probably is worthwhile by the age of 40, 45 to have a one visit with a cardiologist to see where do I stand? Is this something worthwhile I need to do? If your risk factors are high, like if your father or brother had a heart condition in their 40s and 50s, I would start even earlier. You can read, and nowadays YouTube and Google has a plethora of material. You can read as much as you like, but you are paying to a qualified physician who is practicing for 30 years for his independent, unbiased opinion. I would suggest you to listen to it and follow it. Very, very important. I see even my friend circles who take the medication half the time and they say thanks a bunch, and then they stop for 3 years and come back again that, I forgot to take the medications. I would suggest to follow science for problems of matter. Indians often have a feeling that, oh, God will take care of me and I do this and that. And it is not only Indians also. I see it in even Americans sometimes that Jesus Christ would take care of me. But on the other hand, when there is a problem of matter, God has sent physicians to help us. Are they perfect? No. But on the available circumstances, you're not going to get somebody from Mars. Whoever are available locally. So between the cardiologist and your physician, you are very well covered as far as heart is concerned. I wouldn't say use your cardiologist for your cancer problem, then there is a different situation. So that's how I would look at it. Again, that I put that slide earlier, that consider heart checkup once at age 45 for male, age 50 for female. Females have a lead time of about 5 years, but this should move 5 years earlier. If one of your family member had a heart attack below 55 years of age, I would start at 40. 10 years earlier, if family history or diabetes or smoking. So if you are 30-year-old diabetes, I would see a heart doctor. Calcium scoring for appropriate persons. Again, don't overdo it, but don't underdo it when needed. Lifestyle improvement is always worthwhile, but I wouldn't bank on that alone. Medications only if moderate or high risk. If you are very low risk, medications have a less reason to use it. And frankly, your doctors can have, there are online calculators available which can tell you what is your actuarial risk of heart disease over the next 10 years. Is it 2%? Is it 7.5%? Is it 15%? Or is it 20%? Medical science feels that cholesterol medication are worthwhile when your 10-year risk of heart attack is 7.5% or about 7% or more. Then you reduce it. Suppose if your risk is 10% and if you make it 5%, then it is worthwhile to use that medication for 100 people to save heart attack in about 5 people. That's roughly the calculation. And definitely you need to see a heart doctor or a advanced doctor if there are any symptoms of significant nature. But again, should you wait till symptoms? Again, I appreciate the Thana team. Let us see if there are any important questions that I need to address. We may not be able to address all these questions here because of obvious limitation of timing. I have written my email address a couple of times in the chat box, and I will share with Arunji and VC if there are any questions that come up. I do have their email addresses. We are there to answer the questions, but I think time-wise, we may not be able to go through a lot. Let me take 1 or 2 questions, but not a personalized questions. Questions should appeal to all rather than your individual problem. An individual problem, you can email us, we'll try.
Pankaj, say something more about alcohol use.
I did mention alcohol use. I wouldn't recommend for that purpose, but taking a drink or 2 of alcohol doesn't cause heart disease. It may slightly reduce risk, but I wouldn't buy that suggestion. Any other question that comes?
I think a lot of people will be benefited by looking at some very simple site. There was a study done in the US and internationally. It's called Masala study. It was done in South Asian people. And it's actually, there's a bunch of blogs on the site. It's called masalastudy.org. Everyone can go to that site, and it has dietary suggestions. It has a lot of material that people can just look at to help themselves, besides everything else that we've talked about. I see there's a lot of personal questions about diet and so on and so forth. I think all that can be answered there.
How much ghee needed for every day? I wouldn't get hung up on the ghee, and the ghee would not prevent your heart attack and it will not cure it. So have in moderation if you need it. I wouldn't drink spoons of tea. Any other questions?
So there are some interesting questions.
During the talk,
one person at a time, please.
Yeah, there are some interesting questions in the chat box. Can we go through them? Because people are waiting for their answers.
So there are a lot of questions, and I thought my talk has given enough answers. Best ways to reduce cholesterol. Certainly, diet has a role, but in addition, medications when needed are extraordinary. Atorvastatin, rosuvastatin are great medications. As you know, nowadays even injections are available, which work very well. So it can be lowered in more than one ways. Does lower abdominal burning cause cholesterol? It's a weird question. Doesn't make a sense. My direct family member is undergoing bypass this week in India. What is the precautions? And I can send an email. That person Sid, I can, if you email me, I'll send. If you Google, by the way, YouTube has a beautiful videos on almost every questions, like a after bypass surgery what, or heart catheterization. I do have all the list. I have not put it here, but I can send out for those you. Somebody has a nice question, Prince metal angina, and this is a googly, which I would say were in the cricketer term, that what Prince metal angina is. I could go on that depending upon the time, but making it simple. As I told in the beginning, while the most common heart disease is a cholesterol-related blockage, you could have a heart attack with a totally normal heart tubes or totally normal-looking heart tubes. So the heart tube could be wide open like this, but intermittently it undergoes spasm on its own, just like the leg muscles undergo cramp. The heart tube is made of muscles, undergoes spasm, it tightens up, it blocks the tube, causes damage to the heart attack, and even sudden death. And when we do catheterization, we found heart tubes are wide and open. That condition was described by a gentleman called Prince Metal, so it goes by that name. He described that people could have a chest pain from the heart without severe blockage because the tubes are undergoing spasm. Spasm can occur with normal looking tubes or with a say 50% cholesterol buildup also. So you could have some blockage, but not severe, and still have a chest pain. It is treatable, identifiable. The problem is many times these are the young patients, young females or males, and they are considered neurotic, psychotic, and disregarded by the doctors. I see a couple of patients like that every year where they have gone to multiple doctors and emergency room. They had a significant chest tightness, and they were ignored because they were so young. So you could have a heart problem from the heart, and you and your doctors could miss it. That's the relevance of that. There is no substitute to good cardiology and good medicine. I wouldn't underestimate it. If you have a significant symptoms, find a doctor who can address it. So that's a very simple suggestion. Very nice question there. Must be a physician to ask that question. Is there a higher correlation?
Basically, if patient is Prince metal angina, and if they reach to the hospital emergency room with the chest pain ongoing, many times we can diagnose this by ST elevation changes in ECG. So many times we have now medicines which can prevent vasospasm and can reduce chest pain or angina or heart attack related to Prince metal angina. Of course, all Prince metal angina people do need to undergo angiography to be sure that there is no underlying problem. But there is a way to diagnose it and fortunately way to treat it as well. But I agree with you that many times till the diagnosis is done, unless you
there are ways to diagnose it, but many times, usually I diagnose by clinical suspicion and therapeutic trial of nitroglycerin and response to amlodipine. So there are ways to treat it. Somebody asked a question that will coronary calcium score tell us any symptoms? Will it be of any use? I think we already mentioned. It will not tell you of symptoms. Calcium score is an anatomical finding. It is not a physiological finding. You have to correlate with the patient's symptoms and a stress test finding. Arunji and Virendra, if you see any other interesting question that you would like to comment on, please feel free. A lot of questions.
I've actually been trying to answer some of the questions online, and I've just responded to some of them. But I think people got a lot out of our discussion. I just want everyone to know that we are not giving personal medical advice to anybody. It's a general discussion about the high risk for South Asian people regarding their heart disease, and how people can be proactive and take care of themselves and their family members around them, and try to mitigate the risks so that the South Asian community can become being educated, and besides being urbanized and rich and all that, but to survive this serious illness that is taking a lot of our friends out with sudden cardiac death. And in terms of CPR, I think there are so many organizations, Indian organizations throughout the country. There's so many temples, perhaps, starting giving lessons in all these organizations and all the temples to get to the community at large would be a viable option to help the community at large.
Wonderful. I think that helps. So Ramji had a good question, role of stress in heart disease. While often overstressed and sometimes understressed, in the sense a lot of people think that he's like this, that is why he has heart disease. I would say yes, stress has some role to play in heart disease in general. The way I see that, very stressed out, anxiety filled, the so-called type A personality, and that's not misunderstand, I understand both sides of it. But when the lifestyle is like that, it is more likely that the person would be in the habit of eating wrong stuff, maybe smoking, maybe lack of exercises. So it adds up to the other risk factors, and it is more likely that he would suffer from problems. So the stress has a direct, indirect influence on that. Duke did a big study a few years ago. Does the stress or hostility, people who are hostile, people who are very uptight all the time, are they at a higher risk? And they did find the risk is somewhat higher. Would meditation cure all the problems? I'm not sure about that component. Also, taking life lightly and easily, having good doses of laughter are always worthwhile. But if your laughter is accompanied by junky food and a ton of smoking, then you are mistaking the route there. That's how I would see it. So yes, stress has some role, reasonable to lighten it. But if we can all lighten up the stress, we will all be gods, isn't it? Let me see any other question. Virendra, do you see any other interesting question?
Masalastudy.org had a corollary where they looked at people with stress, and they reduced their stress by, like you mentioned, meditation and so on and so forth. And there was a reduction in heart disease. Same way, pranayama from yoga has been studied. It was studied in the jails in America, where they noticed 30% reduction in agitation and anger. And they have a role, but they're not curative. Ultimately, mitigate your risk factors, find out if somebody is high risk, take care of them, and people simply have to take action themselves and not wait for a big event to happen.
I think we have one or two hands raised. If somebody has a question, we'll be glad to.
Someone has asked question, can they eat eggs if cholesterol levels are normal? I would answer yes. Up to 2 eggs a day is not a problem if cholesterol is normal. But as far as white is concerned, boiled egg white can be taken even 4 to 6 depending on degree of exercise levels. But avoid fried egg items. As for example, omelette more than 2 eggs, especially the yellow portion. Because yellow portion is definitely nothing but cholesterol. And it is very easy to remove yellow from the egg than to remove the cholesterol once it goes into your arteries. So take action before it is too late. But 2 eggs per day, if cholesterol is normal, there is no risk factor, is not a problem.
Ramesh, you had a question? You need to unmute yourself. Ramesh, you need to unmute yourself.
You had mentioned about the leg circulation test and about exertion angina. So how are they indicated?
So again, same blockages that occur in the heart tubes, they occur in the leg tubes too. People who are a smoker or diabetics are especially prone to those leg circulation problems. So many times we would check leg circulation for one or the other reason, because person comes with an chest leg pains, then a physician feels that I need a circulation test. So we will do it. And if we find that the leg circulation is deficient, it's an indicator to us that the heart disease is there. Some people would do routine screening of the leg circulation, and it is very easy to do technically. But frankly, with the calcium score coming, I look at the heart. Why would I look at the leg tubes? So, there is a role. But for all practical purposes, if I were in your place, I would do a calcium score of the heart. If there's a blockage or not, your buck stops there. So, it has a role, but I'm not sure I would push you much more. I would not tell you to go ahead and get the leg circulation test done tomorrow, if that's what you're asking me, Rameshji. Did you get the answer?
I think so. I was just wondering, and also
it is a
you
useful,
talked
suppose
about,
it has a utility. Suppose if you come tomorrow and for some reason I did a leg circulation test and there is a blockage there is a 50% less blood pressure in the leg. I know you have a blockage somewhere. Now, if you are 50-year-old and if you have a blockage there, I'm worried about it. Even at 80, it's worried about, but so it is an indirect indicator. But the calcium score is so sensitive, so direct indicator for the heart, that I think that has fallen as a second role for me. Some people may be using more than others, but so it has its role. But I don't recommend my patients to go ahead and get a circulation test to look for the heart, if that's what you're asking.
okay.
You had a second question?
Yes, similarly about the exertion or shortness of breath. And again, I'm talking more about shortness of breath could be caused simply because you are getting old and you may not have the same strength as you were 50-year-old. So when do you indicate
keep
the
in mind,
shortness of breath to be diagnosed?
I understand your question, Rameshji. All these symptoms have their own specificity. The most specific symptom to suggest the heart is on exertion, you get a pressure, tightness, heaviness in the chest, which subsides with rest. That's the number one. However, some would have an exertional shortness of breath rather than chest tightness. I need to keep as a physician in the back of my mind. However, more often people would be either a smoker having shortness of breath, people is obese and deconditioned, people have asthma or bronchitis problems. So there are many other reasons for exertional shortness of breath, but much lesser reason for exertional chest tightness. So that is where physicians' inquisitiveness or accuracy or his ability to pick up comes picture. I frankly tell you, PVC people all the time, where the primary symptom is he was walking 1 year ago like this and now he cannot walk that much. So, a physician, a cardiologist and a physician is tested the most where a common disease presents in an uncommon way. Makes sense? Where I am tested, I may think, and the problem often is a deconditioned person comes to me that I'm short of breath on exertion, and he thinks it's because of deconditioning, but it is my job to make it sure that he's not at a risk of heart attack. So both things could coexist, and that is the worst part of the story, that there could be multiple things sitting together and you would miss if you do not keep that in mind. So as a patient, you may not be able to say. I would suggest you, if your exercise is limited, you go to an appropriate person to know, is it limitation just an average deconditioning, or is there an additional heart disease sitting, contributing to your risk factors? Make sense? It is not your job to diagnose. Your job is to reach appropriate person. That's all that I can say.
Thank you.
Any other questions, or are we ready to wrap up? Varunji, you have a question? Go ahead, please.
Yes, sir. Sir, one question is like, I've seen, the people like, they're good with exercise and they take a good diet, but still it's like the cardiac arrest is happening very frequently with a lot of people I've seen. So there is any specific reason for that, or anything like,
let me give you a classic example of Arthur Ashe, the world-class Wimbledon tennis champ, who had a bypass surgery in his 30s or early 30s, even while he was active tennis player. All of them got clogged up again after a couple of months or years, and he received blood transfusion and died of AIDS at the end. Arthur Ashe is his name. So people have a wrong conception that if I exercise, I would not get a heart condition. It helps. However, if you have a multiple additional risk factors, If you are genetically, in his case, genetics were bad. His grandmother, even though he was from Caribbean origin, his great-grandmother was of South Indian Keralian origin, immigrant Indians from there. That is how his risk factors came from, as far as I understand. I don't know full details, but that's what I was told. So if you have a genetic predisposition, and if you are at a high risk, if you get unusual symptoms, even in 30s, you're better off reaching a physician. I cannot emphasize you enough. I wouldn't take it for granted that just because of I exercise, I would not have a heart condition. Your risk is lower, but it is not gone. Exercise is one component of multifactorial risk factors. You cannot use it as an exclusion of the others. So all need to be aware of it. Does it answer your question?
Yes, sir.
Yes, sir. Gautam,
Yeah.
Gautam.
Yeah, I have a couple of questions. The first thing is, what about the risk with these COVID vaccines and the boosters all, will be getting down the lane?
Arunji, would you like to answer that?
So what we talked about throughout this discussion is coronary artery disease and mitigation of bad happenings, cardiovascular events. As far as the COVID vaccines are concerned, they are being used to prevent serious illness, respiratory failure, and death from COVID. And really is a totally different topic. But
what about the risk for the heart, from the vaccine, like a side effect or whatever?
So the COVID vaccines do not cause coronary artery disease. The risk to the heart is in very small segment of population, not applicable to us. It is the inflammation that is seen in the myocardium, which is totally different disease, and sometimes pericardium, but it's mostly in younger people, and it has nothing to do with coronary artery.
Okay. Yep.
I have seen several patients where soon after the vaccine, within few days, palpitations, atypical chest pain, etc. occur. None of them were life-threatening. So if there's some people, to any vaccine, people can react occasionally abnormally, usually local reaction in the arm. But I've seen few people with the chest pain and palpitations and significant palpitation, but not life-threatening. But heart attack and blockages have not been a concern as far as we know. 20 years down the road, we do not know. But at the moment, it does not increase the risk of heart attacks, death in that sense. It really is worthwhile taking the vaccine, and I would recommend that. Siddharthi, you have a question? Siddharthi Konakanchi.
Yeah, and one more question I have.
Go ahead, please.
Yeah, they generally they say red wine or whatever alcohol will benefit, right, for regular people. But from the masala study which I have looked online, it says it won't benefit any for South Asians. It's mostly for white folks or other Westerners.
I would not drink alcohol to benefit the heart. You enjoy it, one or two, it's your choice. I would not drink it for preventing heart attack, if that's what you're asking me. Arunji, do you have a different opinion? Arunji, I would like to have a second opinion from you.
Alcohol is not known to mitigate heart attacks. So yeah, the study is correct. What you read is correct.
Okay, yeah, especially South Asians, it won't benefit, but it will do harm. That's what, the bottom line of the study, right?
Yeah, in excess, it will do harm. Correct.
Okay, yep. Thank you.
Venkat, do you still have any question?
Yes.
I have a question.
I'm sorry. A question about one bullet said not LDL. Could you explain that?
Well, I need to go back to the slide, but LDL, unfortunately, every decade or so, we come out little more understanding about this. Initially, all that we knew was cholesterol. Then we realized there's a good cholesterol and bad cholesterol. Then we realize even in bad cholesterol, there is a good bad cholesterol and bad cholesterol. So sort of we are improvising. If I were in your place, I would trust your doctor to find that out and see where we stand. I could go in details, but wouldn't help you. But there is a LDL subfraction called a small LDL, which is of bad kind.
No, I think I know the slide that he means. What that slide meant was, look at the picture as a whole for the individual.
Understandable.
not just the LDL. That was the main crux of that slide.
So you could have a 180 LDL with a 90 HDL and 120 LDL with a 20 HDL. So the ratio also matters. It has its own relevance. So these are all spokes of the wheel. You need to look at the whole wheel, where this is one component.
And please don't confuse. In people who have heart disease, we target LDL. We want to lower the LDL. So people who already are on medicine to lower the LDL, please don't confuse that slide with that question. That slide purely meant for what we call primary prevention, where people don't have heart disease, they have risk factors. We look at the person as a whole, treat the diabetes, treat the cholesterol, treat the blood pressure, treat the weight, treat the exercise, the diet, and overall picture, not just focusing on LDL. That's the crux of it.
One more quick question. What is the need for stress test? What is the triggers?
Well, stress test is needed to see if the symptom that a person has, is it from the heart or not. Stress test, regular treadmill test that we do in the office, simple treadmill, I'm not talking of nuclear stress test. Regular treadmill has about 70% accuracy, and that also only if the person exercises about 9-10 minutes of level there. If person exercises 3-4 minutes, then the accuracy of treadmill becomes low. The nuclear stress test, which is more advanced, has about 80-85% accuracy. Catheterization obviously is the gold standard there. So there are different levels. So when needed, treadmill is very helpful. But just because your treadmill is normal, it does not mean you don't have a blockages. You could have a 50% blockage, half of the tube, all the 3 tubes could be half blocked, and your treadmill could still be normal. You could have a 80-90% blockage in a tube, and still your treadmill could be normal, because that's a 70% accuracy. You have a 20-30% inaccuracy of treadmill. So while it is a useful tool, it has a limitation, and a cardiologist knows it. So when we send the patient home, in my back of the mind always is that, is it a false negative treadmill? So that is a judgment, and that is where an advanced test, when available, are very helpful. Right, Arunji, did I say it correct? Anything?
Yeah, absolutely. Like we've mentioned throughout this, that we look at the risk factors and we identify who could have heart disease and who could not. So here we are talking about people who do not have symptoms. So people who do not have symptoms, if coronary calcium score detects heart disease and I do a stress test, they will pass the stress test. But we know that they have heart disease. The stress tests in these people simply have identified this person to be at a lower risk of any major blockage than having a major blockage. And the predictive accuracy of the test is about 70 to 75% in a negative stress test. In a positive stress test in the wrong population, the predictive accuracy drops. In a person who is having symptoms, and we have already discussed that supposing the person has asthma, the stress test is not going to help us because the person may not be able to walk. There, a nuclear stress test may be helpful. But a person who can walk on a treadmill, we are able to differentiate whether that shortness of breath or that chest tightness is coming from heart disease or not. And as we mentioned, the predictive accuracy is not as high. It is high, but it's not 100%.
It would be wrong in general to consider any of this test as a final conclusive test. Even after heart catheterization, person could drop dead if he has, say, Prince metal angina, or if he has a blood clot in the lungs like pulmonary embolism as a cause of chest pain. So that is where shrewdness of the physician and smartness and his constant oversight would be needed when in an individual case. But in a given hands, these tests are extremely helpful. Dr. Kataria, you had a question. Would you like to unmute yourself? You need to unmute yourself. Yes, Ji. You are muted. Ramji, if you can unmute all, please. Next person, if he has anybody else has a question.
Okay, now about the aspirin use. You know, aspirin use, it prevents adhesiveness of the platelets. Now, why do we have to use aspirin every day? Because the effect of aspirin can last for 1 week. Are there any studies where they have looked at using aspirin once or twice a week may be adequate?
Arunji, please.
Because platelets are being born every day. So the aspirin that you took yesterday is effective for the life of the platelets which were born up till yesterday. Their activity is deactivated, but the platelets which are going to be born today and tomorrow, they are not made inactive. So the overall effect of the antiplatelet activity is mitigated. Yes, there is a physician study and there's a nurses study that has been done with aspirin, where they gave low dose aspirin, moderate dose aspirin, and high dose aspirin in these people, and the aspirin was given on a daily basis, and that's one of the studies that showed that too much aspirin can cause brain bleeds, but of course it mitigates it cuts down on the number of heart attacks, but obviously at the risk of.
That's not my question. My question is based on the half-life of aspirin. The half-life of aspirin is 1 week. It's nothing to do with the platelets availability.
Half-life, hold on. Oh, that is an interesting question. Arunji, I will pass it on.
So most of the studies.
We need to mute all, please, again. Go ahead, Arunji.
So most of the studies were done at Mount Sinai with aspirin going back almost 30 years ago. And I think all the studies which were done at Mount Sinai were done with using baby aspirin on a daily basis. I don't recall any study that was done with 3 times a week or every other day. And the only other studies that I'm aware of is the physician study and the nurses study with the low dose, intermediate dose, and high dose aspirin.
You are muted. Yasji, you are muted. You need to unmute yourself. But I understand your question is interesting. If the aspirin stays in the system.
Let me ask you one more question.
For several days, it makes sense there. That's
I know that, coronary artery disease. I mean, you said, coronaries can be normal looking angiogram. And you mentioned about the Prince metal disease, that's okay. Now, what about the small airway, small vessel disease in the myocardium? I mean, that can be missed. The coronaries can be normal on angiogram. How do you detect that small vessel disease?
That's an interesting question also. So we're talking about microvascular disease. So microvascular disease is a very long and different topic. We can talk about it on, for 2 days. But it cannot be detected, like you said, predictively on a normal angiogram. But you can do perfusion studies, myocardial perfusion studies, and myocardial blood flow can be measured using PET, positron emission tomography, and that's how you can tell. Even nuclear studies can show myocardial defects, whereas when you do the angiogram, they don't have any major blockages, and then you know that this could be microvascular disease.
Then let me ask you.
Yes, hold on, Dr. Kataria. We are going to have another medical talk for physicians. I know you are esteemed physicians. This group, others would get bored with the medical questions. So please keep it to the layman's level if you can. Otherwise, you can call me personally and we'll connect as a group call.
Okay.
What is the value of LPA versus calcium test? No comparison. I would not do LPA for that purpose. Calcium test has its own utility by itself. Kiranji, any other question?
I have a question. Yeah. So my father is undergoing a bypass surgery this week in India. So I want to check what is like a lifespan after this bypass surgery.
Email me after that. I tell you, people live 20, 30, 40 years without much problem. It depends on underlying heart and what are the additional problems. not every person is same, right? I mean, if you had a bomb has been bought and dropped on a center of the queue, it doesn't mean all the houses are going to collapse.
Yeah.
So it depends on the degree of problems and how the lifestyle changes and how the medications are taken. But I started practicing in '94 in Raleigh, North Carolina, and I have patients that I saw in the first year who had a bypass surgery or stents, and they are doing in 2021 still well without any problem. Not all of them, but many of them. So, you know, some people do very well over 20 years. Some people do have a problems in between requiring additional balloon stents. But I tell you, by and large, people become more active after bypass surgery or a stent than before. Because before that, they thought that nothing is going to happen to them any time in their life. But now they realize that is a shock to them, and they start exercising and do cardiac rehab and stop eating junky food and blah, blah, blah. So, you know, you could be surprised.
And they can be back to the work, right?
Absolutely, back to more work than ever. If the heart has become very weak because of heart attack, then they might have some limitations.
Okay.
But if it's a white collar job, I don't see a problem.
40% efficiency.
Right. You should speak to your cardiologist for individual cases.
Sure.
Any other question? Venkatji, you have a question still? Okay, he's not there a question. Chalo, it's time to wrap up. I think we had an extensive discussion. Telugu Association of North America, I really appreciate them to give us an opportunity. I know a lot more people than Telugu enjoyed this and they joined. Dr. Gupta, you have been kind to take my cues in between and stops in between. Virendra probably has left, but he has been very gracious to you know, have us this platform. Thank you very much. And Tana, I'll give you back to the platform if you need to, Ramji, if you need to suggest.
Thank you, Pankaj. So kudos to all three of you. So it was wonderful session. So Suresh Garu, would you like to comment?
Yeah, wonderful session, Ram. Thank you so much, Pankaj and team. You know, we really appreciate. Thank you so much.
Let's get. Thank you. Thanks, Arunji. Thank you very much, and a goodbye to everybody.
My pleasure.
Bye.
Thank you all. Yeah, thanks for joining. Thank you, sir. Bye.
Bye.